Good morning and warm welcome to online Anaesthesia update in Zoom platform, sponsored by Akunda and hosted by A1 Rajesh, and our media partner is Anaesthesia TV. Today's recent advances in anesthesia this month is dedicated to AIRWAY update. We have two eminent faculties in AIRWAY, Dr. Apeksh Patwa and Dr. Amit Dikshit. First lecture is Understanding and Optimizing the Laryngoscopy in New Area by Dr. Apeksh Patwa. That will be followed by a lecture on Focused AIRWAY Ultrasound and Armamentarium in Future AIRWAY Management by Dr. Amit Dikshit. Today's session is coordinated by Dr. Rajesh, Jeyaprakash, our team member. Over to you, sir.
Thank you, sir. Good morning, one and all. So today we have two interesting topics on airway management, which is a basic for every anesthesiologist. And we have two stalwarts in the same area to discuss their views on the topics. The first session will be from Dr. Apeksh Patwa, sir, about understanding and optimizing laryngoscopy in new era. Dr. Patwa sir is a legend in the airway management, and he is currently the General Secretary of All India Difficult Airway Association. And he was the one who had actively involved in putting the guidelines, especially this All India Difficult Airway Association guidelines. And he is a faculty for a lot of conferences, both international, regional, national conferences, and he's one who had designed some different types of video laryngoscopes like Patwasha laryngoscope and HFNPO devices, and he had a lot of publications and written book chapters also. We welcome you, sir, Patwa sir, for your topic. Over to you, sir.
Thank you, Dr. Rajesh, for a kind introduction, and thank you, Dr. AIRWAY Johnson and Team Online for giving me opportunity to share my views and to the PGs and consultants. Thank you. Should I able to share my screen? So are you able to see my screen?
Yes, sir.
Yes, sir. Visible, sir.
Okay. So basically, my topic is understanding and optimizing laryngoscopy in this era. So let's start with the different mode of session. It's a music. So video was not clear, but I think most of you are able to hear the noise or hear the voice. So it was a opera music. So why I started with the opera music? Because it's a tribute and salute to Manuel Garcia. He was the inventor of laryngoscopy. He is known as father of laryngology. But if you look at his designation, he was not an ENT surgeon. He was not an anesthesiologist, nor a doctor. He was a professor of singing and singer in opera house. He was the first person who has seen his own larynx. That's why the label of father of laryngoscopy has been awarded to Mr. Manuel Garcia. So my talk is on understanding and optimizing. What do you mean by optimizing? Optimizing laryngoscopy means getting best possible view. That's called optimizing laryngoscopy. And understanding laryngoscopy means perceiving the anatomy and performance of laryngoscopy with analytical thinking. That's called understanding of laryngoscopy. So usually we do a laryngoscopy. For what? We are to create a direct line of sight and to create a passage for the channel for the endotracheal tube to facilitate intubation. That's the purpose of doing laryngoscopy. And it's having three components. First, we need to expose the larynx. Second, we have to make the entry into the vocal cord. And third, we have to make the passage for the endotracheal tube. So let's start with the first part, laryngeal exposure. In the Macintosh Miller blade was introduced in 1941, and 2 years later, Macintosh has introduced the curved blade. Both blades provide good laryngeal view, but optimal laryngeal view is depend on patient head and neck positioning. And in 1936, Maggie was the first person who explained to improve laryngeal view, just keep the pillow underneath the occiput and then extend the neck. And in 1944, McBath and Barrister has given the 3-axial alignment theory. And they stated that flexion of cervical spine and extension of the AO joint align the oropharyngeal laryngeal axis. And that's the reason we are able to get the optimal laryngeal view. So, and this was not a proven thing. Still, it's not a proven thing. It's a hypothesis. And they will explain the hypothesis how axial 3-axis aligns and provide the laryngeal view. And after that, in 1989, the Horton was the person who has exactly defined the angle of cervical flexion and extension of the AO joint. So it defined that neck flexion should be 35 degree and extension of the face plane should be 15 degree. Now, how to achieve this? And in a common terms, we are using this as a sniffing position. We are labeling this position as a sniffing position. To give the sniffing position, you need to flex the spine, and to flex the cervical spine, at least you need to keep 8 to 10 centimeter height below underneath the occiput. And then you need to extend the face plane. So this is how, this is flexion of the cervical spine and this is extension of the AO joint. And how to give the sniffing position? Look at this video. This is flexion of the C-spine. So AO and this face plane extension. This is actual sniffing position. And if you look at this in image intensifier view, look at this. This is flexion of the cervical spine and this will be extension of the AO joint. So to give proper sniffing position, you need to elevate the occiput at 8 to 10 centimeter height from the table and then extend the AO joint. That is actually sniffing position. Fine. So since 2001, means 1944, McBath and Bannister has explained the 3-axial alignment theory. And 2001, Adnet had contested the validity of sniffing position. And in 8 volunteers MRI, he proved that sniffing position do not align the axis. But this study was criticized because only 8 awake non-paralyzed patients were selected. No laryngoscopy was performed. Patients with the potential difficult airways were excluded. So what he did, in the same year, he did another study for more than 396 patients. And he proved that the sniffing position do not improve the alignment of axis. And sniffing position is helpful in specifically in patients with the morbid obesity and with the patient with reduced cervical mobility. And he has suggested to use simple extension when you get difficulty in a of laryngoscopy in a sniffing position. And one another publication by Dr. Lee, he has suggested to use 25-degree head-up position, which improves the laryngeal view significantly. So if you look at the across world publications about the sniffing position, then most of the publications favoring the sniffing position for providing the better laryngeal view. Whether it aligns the axis or not, that's a different matter. So Adnet said, prove it that sniffing position do not align the axis. But sniffing positions provide the better laryngeal view, that is for sure. So these two are different things. One, alignment of axis, and second, better laryngeal view, optimal laryngeal view. So if you look at the Malaysian journal, if you look at the Hindwai publication, if you look at the Kathmandu journal, whatever the journal you take, if you take Anaesthesia journal, whatever. So most of the journals, they are supporting the sniffing position for better laryngeal view. So that's the conclusion of all studies, most of all studies. Sniffing positions provides the best laryngeal exposure. Whether it align the axis or do not align the axis is a different matter. So there are a lot of controversies among the positioning that has forced us to rethink about the laryngoscopy, and which has come up with the new conceptual framework to understand the laryngoscopy, and this framework makes the understanding easier for difficult laryngoscopy. Why we get the difficult laryngoscopy? So according to this Greenland's new conceptual framework, there are two phases of laryngoscopy. One is static phase and another is dynamic phase of laryngoscopy. Static phase is governed by the posterior anatomical structure of the neck. It's called posterior complex. And dynamic phase is governed by the anterior anatomical structure of the neck. That's called anterior complex. So let's look at the static phase. So our head and neck position has been governed by the C-spine and AO joint. So during laryngoscopy, before doing laryngoscopy, we need to give the sniffing, flex the C-spine and extend the AO joint. And we need to maintain that position throughout the performance of laryngoscopy. So it's a static phase. We are not changing the position during the laryngoscopy. So any disturbance, and that's been governed by the posterior anatomical structure of the neck, that is C-spine and AO joint. So any disturbances in C-spine or AO joint leads to difficult positioning and so difficult laryngoscopy. This is the static phase. Now what is dynamic phase? So dynamic phase is a phase, means the anatomical changes which are taking place during the performance of the laryngoscopy is called dynamic phase of laryngoscopy. Like we are making a anatomical changes during the performance, like we are opening the mouth, we are retracting the tongue, we are lifting the epiglottis. These are actual anatomical changes happening during the laryngoscopy. That's why it's called dynamic phase of laryngoscopy, and is governed by the anterior complex, anterior anatomical structure of the neck. Now, what is anterior complex? If you look at this, the area situated behind the hyoid bone is epiglottis, and area situated behind the thyroid is vocal. These are not part of anterior complex. So anterior complex is a imaginary pyramid, and base of that pyramid is formed by the bilateral temporomandibular joint and lower bottom incisor, and apex is formed by the tip of the hyoid bone. So this is called anterior complex. And if you look at the content of anterior complex, look at here. So mainly the content of anterior complex is submandibular tissue and tongue. You can very well appreciate the tongue movement into the anterior complex. Now, what is the clinical significance of this anterior complex? Let's discuss something differently. So this is a mandibular ramus. Suppose there is a narrow mandibular ramus in case of receding mandible. So because of this narrow mandibular ramus, there is a confined space into the anterior complex, and normal tongue, for a normal tongue, is not possible to accommodate into the anterior complex, and this tongue shifted down here into the hypopharynx and it's become a hypopharyngeal tongue. And we are able to retract the oropharyngeal tongue. We are not able to retract the hypopharyngeal tongue, and this leads to difficult laryngoscopy. We'll discuss in another different scenario. Suppose this anterior complex, mandible is normal. This anterior complex is normal, but there is an enlargement of tongue in case of obesity. So because of excessive soft tissue enlargement in the tongue, see this enlarged tongue, for enlarged tongue is not possible to accommodate it by anterior complex. Again, this tongue shifted down here into the hypopharynx, and that's the culprit. And that's the reason of difficult mass ventilation and difficult intubation, as well as development of obstructive sleep apnea. And let's discuss about the hyoid position. See, hyoid is a free bone. It's attached with the few ligaments with the soft tissue and epiglottis. So forward movement of hyoid bone open the airway, and backward movement close the airway. And during dynamic phase of laryngoscopy, look at this video. This is the laryngoscopy in situ. This is mandible. This one is hyoid bone, where my cursor is. Now, if I run a video, during dynamic phase of laryngoscopy, hyoid is drawn anteriorly and forward. At the same time, mandible is also drawn anteriorly and forward. And there is a total compression of the submandibular tissue between this blade and mandible in order to create a direct line of sight. So there is significant amount of shift and compression during the dynamic phase of laryngoscopy. So the success of direct laryngoscopy is depend on one, clinicians or anesthetists' ability to shift submandibular tissue and mandible, make the mandible movement forward. Only then we are able to create a direct line of sight and we are able to create a channel for the passage of the endotracheal tube. And again, this depend on volume of submandibular tissue. Like in case of acromegaly, there is an enlarged tongue. Obesity, there is an enlarged tongue. That leads to difficult laryngoscopy. Compliance of the submandibular tissue, like in case of angioneuritic edema, Ludwig's angina, there is less compliance of the submandibular tissue. We are not able to compress that tongue. We are not able to shift that tongue, leads to difficult laryngoscopy. So this concept explains everything about the difficult laryngoscopy. Now, if you look at the range of temporal and mandibular joint movement, as we know, during dynamic phase of laryngoscopy, mandibular moves anteriorly forward. But if there is a mandibular joint is not allowing to make the forward movement of mandible, that leads to difficult laryngoscopy. Range of stylohyoid ligament. Suppose there is a calcification in stylohyoid ligament. We are not able to make the forward movement or anterior movement of the hyoid, leads to difficult laryngoscopy. And space occupying lesion in the upper airway also leads to difficult laryngoscopy. So this concept explains everything about the laryngoscopy, why it's becoming difficult. So it's very clear that position does not alone provide the optimal laryngeal exposure. We must apply force to achieve optimal exposure. So it's now clear that we need to apply force for a direct laryngoscopy. So is it possible to reduce the requirement of the force? Yes. How? So look at this. That's been explained in 2000 by Dr. Greenland. This is primary curve. It's an oropharyngeal laryngeal curve, and secondary curve is laryngeal-laryngeotracheal curve. Fine. So this is the primary curve, and this is the line of sight. So if you look at the area between the primary curve and line of sight, is mainly a submandibular tissue and tongue. So if we are able to reduce this area, it decreases the force of requirement. So what we are doing during the conventional laryngoscopy, we are shifting this submandibular tissue, mainly tongue, above the line of sight to create a line of sight. So now, if you look at the area in a neutral position between primary curve and line of sight, it's this much of area. If you change from neutral to extension, because of stretching of the submandibular tissue, the area reduces. If you further change from extension to sniffing, which further reduces. And as per this publication, if you change the position from neutral to sniffing position, there will be a 10% reduction in the submandibular tissue area. So if there is a 10% reduction, there is a less force is required. So in sniffing position compared to neutral position. And if you look at the direction of the tube or channel for the passage of the endotracheal tube in neutral is like this, is angled. But if you look at sniffing, it's straight. So that is the reason we should use sniffing position for direct laryngoscopy. One is decreases the submandibular tissue area, decrease the force of laryngoscopy, and it provides the direct channel for the passage of the endotracheal tube compared to neutral position. And that is the reason we should use sniffing position, not other position. And that is the reason sniffing position. This is the reason why sniffing position to be used for laryngoscopy, not because it aligns the axis or do not align the axis. That concept has been changed. So what happens from neutral to extension? Neutral to sniffing, this primary curve becomes flattened and decreases the submandibular tissue area between the line of sight and primary curve, and that decreases the force of laryngoscopy. So snipping position provides the better laryngeal exposure with relatively less force of laryngoscopy compared to other position and facilitate the better pressure of the endotracheal tube. So in short, the success of laryngoscopy is summation of one, positioning, means posterior complex flexibility. Second, favorable anterior complex anatomy and compliance. And third is our ability to retract and compress the submandibular tissue. So if these three things placing at one time, then we'll be able to having optimal laryngeal view. And many other factors affects the laryngeal view. That is external laryngeal manipulation. What is external laryngeal manipulation? So subconscious level, we are asking our assistant to press the thyroid cartilage to get the view. That is called bimanual laryngoscopy. And there are a number of varieties of bimanual laryngoscopy, but modified bilaryngoscopy is more effective. In modified bimanual laryngoscopy, what we are doing, one person is doing the laryngoscopy, and that person, the performance is guiding the assistant hand to compress the thyroid cartilage. That's called modified bimanual laryngoscopy. And even light, see, brighter light doesn't mean you'll get the optimal laryngeal view. You'll get the proper laryngeal view. So optimal light should be 700 lux in the any laryngoscope. And brighter laryngoscope may not be necessarily a better one. What should be the table height for a better laryngeal view? So this is absolutely wrong. Your umbilical, lower lip margin umbilical, your table height should be at the level of nipple or Xafford process to get the better laryngeal view. And even McCoy blade improves the laryngeal view with less force of laryngoscopy. Look at this. So from here onward, we are just bending the tip of the McCoy blade, which make the forward movement of the heart and open the larynx with lesser force compared to other blade. So it makes the intubation faster, laryngoscopy faster and easier. And it significantly improves the laryngeal view. So in short, laryngoscopy is all about, it's a summation of proper positioning, favorable anterior complex anatomy, appropriate force of laryngoscopy. If required, we need to give a bimanual laryngeal manipulation. Your light source should be enough to provide the 700 lux, and your table height should be optimal as discussed. So I thank Dr. Greenland for providing this insight about the laryngoscopy. So do we have time, Dr. Johnson, so I can cover the understanding of video laryngoscopy?
Sir, you can cover.
Okay. So these are the problems with the direct laryngoscopy. We need to create a direct line of sight. We need to apply force. We need to give an external laryngeal manipulation. We need to have a favorable anterior complex anatomy. And we need to have proper flexibility of the C-spine and O joint. So these are the problems with the direct laryngoscopy. So to understand video laryngoscopy, we need to discuss the problems of the direct laryngoscopy and how to overcome this problem. So if you look at the most of the guideline, 2020 ASA guideline, 2016 ADA guideline, 2015 DAS guideline, all guidelines recommending the use of video laryngoscope. So these questions now do not arise, whether it's time to say goodbye or whether it's time to share flashlight. So now video laryngoscope has proved itself. And if you look at this recent systematic Cochrane review of 6 years back, with 64 studies, inclusion of more than 7044 patients. And they stated that the conclusion was VL improves the view in predicted difficult intubation compared to direct laryngoscopy. VL improves the glottic view irrespective of predicted or known difficulty. It reduces the incidence of airway and laryngeal trauma. And most of all guidelines as discussed suggested the use of video laryngoscopy as an initial approach. So video laryngoscopy has proved its ability. But important thing is that where we are lacking, which type of video laryngoscope we use. Hyperangulated, angulated, channel, non-channel, Macintosh type, which position we should use, sniffing, neutral, ramp, and we don't have a definitive criteria to predict the difficult laryngoscopy. What are the criteria there for predicting difficult laryngoscopy? Is there for the laryngoscopy, not for the predicting the difficult video laryngoscopy. So we need to define that criteria. So to understand that, we need to understand what is video laryngoscope. And nowadays, compact, robust, high-resolution micro camera are available, which is to be embedded on the tip of the scope, which convert any scope into a video laryngoscope. And many people using this, they attaching that camera on the Macintosh type of blade. So will this serve the purpose of overcoming the problems of the direct laryngoscopy? Let's discuss that. So how video laryngoscope works? So again, three components of anesthescopy. First, laryngeal exposure. Second, getting into the larynx. And third, pressure of the endotracheal tube. And this is where, again, Greenland and explain how video laryngoscope works. We discuss about the primary curve and secondary curve. If you look at the meeting line between the primary curve and secondary curve is in the laryngeal vestibule. And this is relatively straight line. And if you are placing the camera over this line and its camera is facing towards the larynx, you will get the laryngeal view. Sorry, there is some. And you will get the laryngeal view. That's the basics behind the direct laryngoscopy. The basic behind the video laryngoscopy. So you need to place a camera over this line to get the laryngeal. That's the basic. So indirectly, we are shifting our eyesight into the pharynx to take the image of larynx. So line of vision is only this much. It's a totally different from the line of vision we are creating with the direct laryngoscopy. And as we are creating only this much line of vision, in short, it enables video laryngoscope enable us to look beyond the curve of tongue. And that's the reason it provides a better laryngeal view by eliminating the need of oropharyngeal laryngeal axial alignment and tissue compression. So now, if you look at the different video laryngoscope, there is a difference in the angle. If you look at the AIRTRAC and King Vision, so its angle is like this. So this angle of video laryngoscope, AIRTRAC or Pentax or King Vision is matching with the primary curve. That's why it's called anatomically curved blade. And if you look at the CMAC D blade or GlideScope hyperangulated blade, if you look at the angle of this video laryngoscope, is matching with the primary curve of the oropharynx. So again, it's an anatomically curved blade. But if you look at the Macintosh type video laryngoscope, when it's in situ, the curve is like this. So it's not matching with the primary curve of oropharynx. It's called Macintosh type of blade. It's a non-anatomically curved blade. So if you want to classify the video laryngoscopy, it can be classified as anatomically curved blade, J-shape, in that it is J-shape, that is with the King Vision, AIRTRAC, Pentax. And hyperangulated is a CMAC D blade or GlideScope hyperangulated blade. And anatomically curved, non-anatomically curved blade is a Macintosh type of blade. So these are the difference between anatomically curved blade and anatomically non-anatomically curved blade. What does it make difference in a clinical practice? We'll discuss in a later part of this session. So if you look at the different video laryngoscope, you are having more than 90-degree angulation, few are having 90-degree angulation. What does it make difference to us? Higher the angle, the camera is much near to the larynx. Lower the angle, camera is a little bit away from the larynx. Look at this. Hyperangulated where camera is much near to the larynx. And simple J-shape angulation, camera is a little bit away from the larynx. What does it make difference to us? Whether it is near to the larynx or away from the larynx. When camera is near to larynx, it provides almost near 90 to 100% focus scoring. And when it is away from the larynx, like in the King Vision or Pentax, it provides the panoramic view. So both is having advantage and disadvantage. whether it's near or whether it's little bit away from the larynx. So what's the position of camera and what's the clinical impact? It's having clinical impact on the laryngeal view, force of laryngoscopy, and manipulation. We'll discuss it one by one. So if you look at the King Vision or AirTrack or Pentax, the camera is positioned little bit away from the larynx here, this red pointer, and it's looking straight. As it's looking straight, many times you get 50 to 60% progress. You will not get 80 to 100% progress scoring. And epiglottis partially block the view in this case. So to get the complete view, little bit of force is required. You need to lift this camera upward. So many times with this type of laryngoscope, you need to make an upward movement of the upward lift of the laryngoscope to get the complete view. If you look at the hyperangulated blade, the camera is positioned when it's in situ, either with glide scope or CMAC D blade. Camera will position much nearer to the larynx, but it's on the meeting line between the primary curve and secondary curve, and it's looking straight towards the larynx. So the difference between the Macintosh type of blade and hyperangulated blade. So in Macintosh direct laryngoscopy, we are looking upside down. While in case of hyperangulated blade or angulated blade, we are looking downside up. That's the difference. As we are looking downside up, we are in most of the cases, epiglottis is not blocking the view, and we get the good progress scoring compared to direct laryngoscopy. So that's the difference between direct laryngoscopy and video laryngoscopy. And if you look at using the Macintosh type video laryngoscope, camera is positioned here, it's looking upside down. Epiglottis can partially block the view. And still, if you are using Macintosh type of video laryngoscope, still you need to lift this tongue above this line. So Macintosh type of video laryngoscope do not decrease the force of laryngoscope. It do not enable us to look beyond the curve of tongue. To look at this angle, J-shaped angulation with King Vision, it's very little bit difficult to insert the blade into the oropharynx. But if you use the hyperangulated blade, it's more difficult to insert the blade in the midline. But if you look, the Macintosh type video laryngoscope is easy to insert. So that is the one reason insertion is little bit tricky in video laryngoscope in midline compared to direct laryngoscope or Macintosh type of video laryngoscope. That increases the time to intubate the patient with the video laryngoscope. I think we discussed this part, what is the classification. And we were lacking in the predicting the difficult video laryngoscopy. This was the first publication who have defined the predictors for video laryngoscopy. And very interesting, according to this publication, sniffing position is an independent predictor for difficult video laryngoscopy. That means that if you are using anatomically curved blade, you should go for a neutral or RAM position. You should not use sniffing position because it's an independent predictor for difficult video laryngoscopy. So narrow mouth opening is again a difficult predictor for the video laryngoscopy. Now, see what is viewing angle of video laryngoscopy and what's its clinical impact. So our eyes is its own perimetry and we can't look beyond that perimetry. Same way, each video laryngoscopic camera is own perimetry. That's called viewing angle of that video laryngoscope. And there is this video angle ranges from 55 to 90 degree viewing angle of camera. So if you look at the narrow angle camera, somebody is doing narrow angle camera of 55 to 65 degree. Suppose this is an object and this is camera. What? So narrow angle camera will be able to see only this much yellow line area. But if you want to see whole area, you need to withdraw the camera a little bit backward to get the whole object in the screen. But if you are using wide viewing angle camera, then you will get, in spite of near distance from the larynx, you will get the complete laryngeal view. So this is narrow angle camera, this is wide angle camera. I think So this is the picture taken from the narrow angle camera. You won't see the adjacent structure near to the larynx. And this is narrow angle camera. If you are having the wide angle camera, you will see the adjacent structure. So when you are using the wide angle camera, you can maneuver the tip towards the larynx because tip is visualized much earlier compared to the narrow angle camera. So that's about the laryngeal exposure. Now we'll discuss about the entry into the larynx. So with the direct laryngoscopy, we are creating a direct line of sight. But with video laryngoscopy, camera is here. We need to maneuver the tube along the oropharyngeal curve, along the primary curve, along the curve of the blade. That requires pre-shaping of the endothecal tube. And we need to use the pre-shaped, pre-stillated endothecal tube and pre-shaping as per the curve of oropharynx, as per the curve of laryngoscopic blade is mandatory. So you need to pre-shape as per the curve of the laryngoscope. Or usually J-shape hockey stick pre-shaping is in most of the video laryngoscopy is sufficient. Another problem with the video laryngoscopy, few video laryngoscopy is having screen on the top, few is having on the table. And you need to do a intubation and laryngoscopy in the oropharynx looking at the screen. And you need to frequently change your eyesight from screen to oropharynx to screen. That require hand-eye coordination. So because of two things, it requires pre-shaping and hand-eye coordination. It increases the time to intubation compared to direct laryngoscopy. So third part of video laryngoscopy intubation is the passage of the endothecal tube. So we are not creating a direct channel for the passage of an endothecal tube with the video laryngoscopy. So endothecal tube has to be moved as per the oropharyngeal-laryngothecal curve. So look at this. Suppose this is the video laryngoscopy in C2. And this is the trachea which travel downward. This causes disparity of angle between the video laryngoscopic blade and tracheal direction. And this causes difficult passage of the endothecal tube. So you need to maneuver, you need to keep the stillated tube there. You need to withdraw the stillet and advance the tube. Then and then you'll be able to move the tube forward. And if you try to pass the tube directly, it's going to hit the entire part of the larynx. So hyperangulated video laryngoscope require pre-shaping, hand-eye coordination, difficulty in making entry, increase the time to intubation, and difficult passage of the endothecal tube. To overcome that, few companies come out with a slide slot on the laryngoscope. That's called channel video laryngoscope. And with channel video laryngoscope, it makes the line of vision and line of insertion one. And that decreases the time to intubation, and you do not require to use the stillet. So the time to intubation is comparable with the direct laryngoscopy, with the channel video laryngoscope. So advantage of channel video laryngoscope over hyperangulated blade is makes the line of vision and line of insertion one. Do not require stillet, require less time to intubate, and you can perform the awake intubation. This is one of the video of performing the awake intubation in post-mandibulectomy case for redo surgery. It's a nasothecal intubation. We have used the non-channel video laryngoscope blade, passing a tube to the nasopharynx and asking the patient to open mouth. We have given the bilateral larynx, superior laryngeal nerve block and transcripted spray. And look, I'm not giving any force. Able to see the vocal cord and epiglottis. So with hyperangulated blade, it's possible to intubate in awake state. And even you can intubate in a neutral position also. You can use the video laryngoscope for checking the laryngeal movement after thyroid surgery in awake state with the spray. So what are the troubles we are getting during the channel video laryngoscope? Many times you are not getting the high Pogo score, not able to negotiate the tube in the larynx. You'll get the laryngeal impingement. And in most of the time with the channel video laryngoscope, your tube is get lodged at the right area of the fold. Even it's possible to get lodged at the left epiglottic impingement. So how to overcome this? Suppose your tube is getting lodged at the right area epiglottic fold. Look at this. My tube is getting lodged at the right area epiglottic fold. So withdraw the tube, withdraw the scope little bit, and move in the same direction towards right. That will align the tube trajectory with the larynx, and then you can easily insert the tube inside. So this type of maneuvering is required to overcome the troubles. So what type of scope manipulation is required to overcome the trouble? Many times you need to withdraw the scope. Many times you have to rotate the scope. Many times you need to lift up the scope anteriorly, specifically channel video laryngoscope. And tube manipulation in form of withdrawing the tube and 90-degree counterclockwise rotation most of the times overcome the right area epiglottic pin band. So simple clinical pulse of video laryngoscopy. If you are master in Macintosh laryngoscope, direct laryngoscope, it doesn't mean that you are going to achieve same skill in video laryngoscopy. It do not equate to the skill with a video laryngoscope. You need to learn the different video laryngoscopy technique, even if you are master in the direct laryngoscope. So another is, if you are master in one video laryngoscope, it does not equate to the skill with other video laryngoscope. You need to understand the other video laryngoscope. You need to understand the curve of other video laryngoscope, and you need to make the movement according to the curve of other video laryngoscope. Good video laryngoscopic view do not guarantee intubation. Boogie may not be the solution when there is a difficulty with video laryngoscopy. Video laryngoscopy chosen must be selected according to indication. So if you are using for a difficult airway, then you should have anatomically curved blade. If you are using for a routine case, then you should have both type of blade, angulated, anatomically curved, and Macintosh blade. Specifically in predicted difficult airway, you should have anatomically curved blade. In presence of blood, you should have Macintosh type of blade. So these are the lacuna in the video laryngoscopy. Like what to do if we failed with the video laryngoscopy? What next? We don't have enough evidence. Should we go ahead with the other video laryngoscope, or should we go ahead with the direct laryngoscope? We don't have a clear-cut evidence-based guideline for this question. How to define and predict a difficult video laryngoscopy? Till date, we are having only 2 or 3 publications on this direction. Situated based comparative performance of all video laryngoscope, we don't have. Still we are lacking. What is ideal video laryngoscope? No one is able to define. Anyone? I don't know. Thank you.
Thank you. Clear and extensive, easy to understand way of presentation. Rajesh sir, you can proceed with the question.
Thank you, sir.
So in your experience, which video laryngoscopy will advise?
Can you hear me, sir?
Beginners, sir.
Hello, I didn't get you. So, what are you telling?
For the beginners, which video laryngoscope they can go for?
Yeah, that's a very tricky question. Which video laryngoscope they should go for? The video laryngoscope in which they are having maximum expertise, they should purchase that one. Don't go for a newer one. They have not done the training. Or if you're purchasing some, get adequate optimal training before going for a difficult cases. Start with the normal case first and then go for a difficult cases. And make it as a routine. If you are having a video laryngoscope, make it as routine.
So the type is not important. The training you get is more important.
Type and trace ideally. So video laryngoscopy chosen as per the indications. So if you want to handle the difficult airway cases, then you should have at least anatomically curved blade. Macintosh blade is easy to learn and easy to use. But in case of difficult airway, you must have anatomically curved blade.
Understood. Rajesh sir.
Yes, sir. Sir, we have some queries here, sir. Sir, can you hear me, sir?
Yes, sir.
Yes. Sir, the first doubt is like for conventional laryngoscopy, should we use jelly-based gel type pillows or routine pillows to get that sleeping position, which will
So
be the ideal?
you can use any type of pillow, but you have to make it sure patient occiput should be at least 7 to 10 centimeter higher than the level of table. That's very important. Occiput should be at the 7 to 10 centimeter higher than the rest of the table. That is very important, rest of the body.
Sir, there is a question like, is there any video laryngoscope which supports the oxygen supplementation through the scope itself?
So few companies come out with the small oxygen cannula. I think 2U is one of that, is providing with the oxygen channel. But looking at the coming newer era, newer evidences and newer research, if you are using 15 liter per minute oxygen flow through the nasal cannula, it provides the apneic oxygenation. Then you don't need to supplement the oxygen through the channel of the video laryngoscope. So use that. So we have made a protocol. In whatever the patient we are inducing is always with the 15 liter per minute oxygen is flowing through the nasal cannula. But because it increases the non-hypoxic apnea time.
Sir, regarding the positioning for video laryngoscopy, should the patient head end should be at the level of the our xiphisternum, or should the table be down for the easy introduction of?
Important thing, easy introduction. First thing, do not use sniffing position. It should be either extended or neutral position.
Sir, for the tube insertion in video laryngoscope, will that external laryngeal maneuver help, or should we only depend on the change in the handling of video laryngoscope?
See, it depends which type of blade you are using. If you are using hyperangulated blade, means you are looking downside up. You'll get 80 to 60. Then you need to maneuver the scope rather than external laryngeal manipulation. External laryngeal manipulation is help specifically in Macintosh type of laryngoscope, not with the angulated blade.
I think we have taken up almost all the questions here. Edward sir, are we missing any questions, sir?
No more questions, sir. Most of the time they find they are easily able to visualize the vocal cord, but not able to get into it. Any tips you can give?
See, there are few maneuvers, specifically those who are using non-channel hyperangulated blade. See, as there is a disparity of angle between the video laryngoscopic blade and direction of the trachea, disparity of angle, that creates the problem. So if you try to pass dilated tube, it's going to hit the anterior part of trachea. So what you should do, take the tube up to the larynx, don't insert inside. Don't go into the don't go into the vocal cord. Withdraw the stellate 1 to 2 centimeters and keep the stellate there and then advance the tube. That decreases the chances of failure.
And
is there any role for bougie in video laryngoscopic intubation, sir?
Hyperangulated blade, angulated blade, there is no role of bougie. Because many bougies are malleable and it cannot take the actual oropharyngeal or shape or the shape as per the laryngoscopic blade. You find more difficulty.
the CMAC, they have supplied a J-shaped stellate.
Yes. Many companies are now supplying with the J-shaped stellate.
Thank you so much, sir. Rajesh sir, we can move to the second topic.
Thank you, sir. Thank you. And thank you, sir. Thank you, sir. Thank you very much, sir. And we'll move on to the next session, sir. And the next session is on it's a little bit of advanced airway management. It's a focused airway ultrasound in an armamentarium in this future era. The topic by Dr. Amit Dikshit, who is a consultant anesthetist from Ruby Hall Clinic, Pune. He is a very known, very well known faculty for all those who attend this AORA conferences regularly, because he is very much attached with that AORA conferences and the Regional Anesthesia Fellowship of AORA, and he is a board member of Studies of Indian AORA India Fellowship, and he is also member of Perioperative Intensive Care Echo and Ultrasound Foundation, and is conducting a lot of workshops related to focus, related to regional anesthesia, and he had given a lot of publications also in that. And during this COVID era, his contribution with the focus of lung ultrasound helped excellently in many centers to get excellent results. Thank you very much, sir, for that your contribution, and welcome, sir, for your topic.
Yeah, thank you, Rajesh sir, and thank you, Dr. Edward, for giving me this wonderful topic for presentation. Am I audible, sir? Are slides visible?
Visible, sir.
Yeah, thank you, sir. So this is another interesting topic, and I was thinking why this title was chosen, and I could clearly see that this is one of the wonderful article which has inspired many, the focused airway ultrasound and armamentarium in future airway management from emergency and critical care medicine in 2019. And what are we knowing today with ultrasound and airway? I must admit that ultrasounding is providing us phenomenal information, and we still have to analyze, we still have to look at it as how we can apply. And today morning, after lecture of Dr. Apeksh sir, he was talking about the volume of the submental space, and how, so all these structures are seen with ultrasound. Now all these studies are coming up, and how we can utilize it to our clinical decision making is another challenge. So today I'm just going to share what are the possibilities, what is our experience, where we are trying, where what are the challenges. And there are no specific ready-made answers, because this area is evolving, and you have to find in your setup where you can utilize it for the betterment of your own patients. So why this airway is challenging is because airway is a dynamic phenomena, and most of the ultrasound structures, when we do regional blocks or anything, they are most of the time static in a way. They don't change too much every movement. And airway is one thing where we have CT plates, and CT plate has limitations, because airway can see with inspiration, expiration what changes are happening in soft tissue, and therefore it is still we are analyzing all the information and trying to create some valid outcomes which can help us with changes. So these were some of the challenges. Greetings to you all from my hospital. It's a 750-bedded multi-speciality hospital. We have regional anesthesia fellowship, and Dr. Rajesh sir has, I'm really grateful. This COVID time has helped us to grow in various areas, and focus is one of those areas where many departments have come together and started working together. It is like just instead of Atmanirbhar Bharat, it is like an Atmanirbhar physician or an Atmanirbhar anesthetist. We want to make our own bread, and we do not wish to depend on a pulmonologist or a cardiologist or anybody else to tell us. So we are analyzing. Most of the time radiology technicians were not available, and we have to make all those decisions. So I think ultrasound has proven its role beyond doubt. So is airway ultrasound a toy or a tool? Because this was the question asked to me several times, and I think you will be able to answer this question after my presentation. So you can decide, because though initially you may start it as a toy, eventually you will realize its importance when some of the lives are saved, some complications are avoided, and you can decide for yourself. So disclosure, nothing to disclose. Photos and videos which I'll be showing are from my own volunteers and patients, and I'll be showing some of the ultrasound videos also. But we do have different machines. So I'm not endorsing any specific machine, but yes, any new machine is good machine, and the machine which you are into practice, you can utilize it to with a better advantage. So outline of my talk, I'll not be touching more on basics of ultrasound. I'll tell you what is the focus approach and how to handle airway and topics related with airway ultrasound. So what is ultrasound imaging? Some of you might have seen my presentations previously on focus as well. And this is, you always see something black and white and you don't know what is what. And what is ultrasound training is, we see this, some of us must have done the elementary and intermediate drawing exam where we have to write something, Mera Bharat Mahan, and you just draw some pattern. So this is Lee Day to France, something. Nobody knows what is this, but some of you can see a cyclist here. Yes, there is a cyclist. So this is cycle racing across France. So the picture is self-explanatory. So this is pattern recognition. So ultrasound training, when we look at ultrasound, we see some pattern. And when we know that, yes, these are tracheal rings, string of pearls, this is cricoid cartilage, and somebody is telling us, and then we start recognizing this pattern. And then we memorize this pattern and we try to correlate with our regular findings. So ultrasound training is basically pattern recognition. More you are exposed to different patterns and you memorize them and you try to see the ideal pattern and see the variation, you'll pick up so many things. So what is point of care approach? And this is one everyone must understand. We are not assessing like a radiologist. Just go and assess airway, no, nothing like that. We have a very specific question, and that is called focus approach. Whenever the answer is binary in form of yes or no, is this patient a case of pneumothorax? Yes or no? Is it endobronchial intubation? Yes or no? Is this size of tube enough for this patient? Yes or no? Is intubation difficult? Yes or no? So all these, what is the tongue thickness? What is the, so all these are yes, no questions. We do not assess every time whole of airway for each and every patient. We have some specific question and we help each other by identity. So unless you train yourself to ask a right question, that is a focus question, you will not get the right answer. So it should be a specific question. It is time sensitive. It is limited evaluation, and it is refining the differential diagnosis and guiding my treatment. So whether it is pre-op, whether it is intra-op, cricothyroid puncture, many uses we'll see now, post-extubation stridor. So very specific question, after thyroid surgery, are vocal cords moving or not? Yes or no, something like that. So I'm doing that specific interrogation at that point of time to find answers. So what is the evidence of focus? I am a regional anesthetist. I've done my fellowship in regional anesthesia. And there are many articles where, anesthetist, because who all are doing airway, especially broadly, the intensive group. Then we have cardiac anesthetist and pediatric anesthetist, and then all the general anesthetists. So this general anesthetist in general, or the physicians, the emergency physicians, they follow many of the standard articles, and one of them in ASRA, they have come up with these guidelines that if you do focus scanning for at least 30 patients for airway, you are a level 1 provider. And I think this number is not very big. 30, you can easily become a level 1 provider, and additional 220 supervised. So it's not a very difficult task if you follow 2 or 3 conferences, workshops. You even 1 week training is good enough training to make you, you will have good success with. So I have some PG students coming from different institute to my institute, and they were doing some thesis, and they got some skill set. So 1 and 2 hours of training also is enough to help them with acquiring of good images, and a little bit of practice they can improve in that. So it's a good news for all of us. Different probes. So it depends on the which airway you are assessing. By and large, we require a smaller footprint because of the airway, and we use linear probe, and as well as we use curvilinear probe. Curvilinear probe we use for tongue thickness and hyomental distance ratio for assessing neck mobility. Otherwise, most of the time, the work is done with a linear probe. We need to know about where is the orientation marker, the gain, the depth. I'm not going into that details. Ergonomics. Sometimes we have to assess airway in sitting position. We get numerous calls from ICU for intubation for patients in stridor. We have to do awake fiber optic intubation in sitting position. They cannot lie down. So you can assess airway in sitting position. You can also assess airway in lying down position. Dr. Apeksh sir has already highlighted the importance of different positioning, and with a log roll, neutral position, and how we should achieve flexion at neck, cervical, and extension at atlanto-occipital joint and everything. So by and large, for ultrasound assessment, you will read in literature, people talk about neutral head position and hyperextended neck. So extended and neutral, these are the two positions by which we are assessing the neck. Probe orientation, it can be sagittal and transverse. The most important thing is we need to understand anatomy first, and what structures we are anticipating, what structures we should anticipate. So here the thyroid cartilage, the purple one, is like the Dhruva Tara, or something like a Viru Montanum for a urologist, how they depend on that. So Adam's apple, everyone can fill their own Adam's apple. And then there are structures above Adam's apple, and then there are structures below Adam's apple. So now from ultrasound point of view, what are the structures and which are visible from above the Adam's apple and below the Adam's apple? So at the Adam's apple, if you look in the cross section of Adam's apple, the thyroid cartilage, you see vocal cords. So just exactly the cut section you will see. So when we are talking of Adam's apple, it is at the vocal cord level. Then the structure above the vocal cord. So this green one, you can I have to highlight here. The biggest one is the Adam's apple, which is green in color. The purple here is the cricoid cartilage. In between is the cricothyroid membrane. These are the tracheal rings lower down. I think I'll use a pointer. There may be some delay, so I'll just use this pointer. Now I think it's. So this green one is the bigger one, is the Adam's apple, and if you do a cross section, you will see vocal cords just in the cross section area. Below that, you have this yellow one is the cricothyroid membrane. Then we have a cricoid cartilage, and below are the tracheal rings. Now, so the structures above the vocal cord, I am going to see epiglottis, yes, and there are then we have hyoid bone, then we have tongue, and we'll be seeing hyomental distance ratio and other things. Now, below the vocal cords, I have this cricothyroid membrane, then we have this cricoid cartilage, and I'm going to see the tracheal rings and the esophagus. So the cross-sectional anatomy we need to know. Now, when we talk about difficult airway, we are talking about the soft tissues, the presence of soft tissues on the anterior neck surface. So you will see all those calculations like skin to epiglottis, skin to vocal cord, skin to hyoid bone, skin to isthmus. So all these are basically trying to gauge how much is the soft tissue on the anterior neck surface, and it can be seen in neutral position as well as in hyperextended neck position. So is there any displacement as with positioning of the patient? So these are the parameters which we'll be assessing. So again, the hyoid bone on the top, the tongue, the hyoid bone, then we have epiglottis, then at the level of thyroid cartilage, we have the vocal cords, then the cricoid cartilage in between the cricothyroid membrane, and below are the tracheal rings, the thyroid, the isthmus, and other things. All right. So we'll move with ultrasound and intubation first. So what are the advantages at the time of intubation? Now, this is the position of where you can park your probe, usually at the level of C7 vertebra lower down, where in one go you see trachea as well as you see esophagus. So when both are seen in one view, it gives me peace of mind, because most of the time when my PGs and fellows are intubating, I really want to know where the tube has gone. Most of the time the junior most PG will almost go in meditation, and he will be like nothing to speak, and we are so worried what is happening, where is the tube, and they will not tell anything. So it really actually increases the anxiety. I am sure those who are using video laryngoscope and other teaching tools, and if that's the practice, everyone is quite relaxed. But I think with ultrasound, if you have a probe there, it will definitely guide you where the tube is going. So even in pediatric patients, when people are not sure about what should be the diameter, what should be the tracheal diameter, which size tube we should use. So here in the subglottic area, we can definitely assess the diameter, and it tells us about the external diameter. So all these ET tubes, 6, 7, 8, 9, these are all the internal diameters. The external diameter is printed on the ET tube. So 9 number ET tube will have an external diameter of around 1.25 or something. So you just have to see the diameter and choose what size tube you can have, and accordingly. So most of the time pediatric patients we do struggle with number of tubes, and that should, at least it will give you a fair idea what should be the tube we should be selecting. So when we see trachea and when we see esophagus, it is just difficult to miss the esophagus. We can ask the patient to deglute beforehand, and we know where the the probe to be parked. And this has happened to me, 2 weeks back, when I was just parking my probe there and seeing what is happening. And already I was with another consultant that time, and so we had a discussion that this could be difficult intubation. There was a little retrognath here. And so he first just passed the bougie, and it was a routine laryngoscopy. And as he has passed the bougie, I could clearly see that bougie has gone in the esophagus. And I could warn him, see, the bougie is already in the esophagus. There is no point, passing the tube over it and then checking it. So before any ETCO2 reading or before any ventilation, I could clearly see that we have missed the trachea, the bougie, and the movement is clearly seen in the esophagus. And this has happened for 3 times. And for all those 3 times, I have just warned him, withdraw it, you have missed it. And then we did some external laryngeal manipulation, and then somehow little bit of change of flexi tip, and we were able to pass the bougie. And then I told him that yes, this time the bougie is not there in the esophagus, and I could feel the bougie in the trachea as well. And then the tube was passed, and we could see those tracheal signs, and we clearly appreciate the movement in the trachea as well, and we could save. That has given us a good confidence that how it can be utilized for all these patients. And we could have wasted a lot of time, and sometimes in laparoscopic surgery, when we pass the tube in esophagus and put a lot of air, the surgeons are unhappy at the time of laparoscopic cholecystectomy, or because after later we pass the Riles tube, it may not get deflated that much. So it's better to avoid, in the first go. And there are now ACLS guidelines that you can park the probe here, and after COVID, nobody wants to actually ventilate and get that 6 trace of ETCO to confirm the tube. So it's very good idea that before getting or starting any umbuing or attaching ventilation, we are very well aware that where the tube has gone. So if it has gone in esophagus, I am sure if you have seen once only, you will realize that you just cannot miss ET tube in esophagus. You can clearly see the Riles tube also. Sometimes Riles tube is also a big challenge in oncosurgery theaters where the tube has gone, where the Riles tube has gone. And just by placing the probe, we are very confident, yes, it is correctly in position and you can utilize it for, feeding through Riles tube. That's a big challenge. So confirmation is a good idea. So I'm just showing you this video. I think this, I'll play this video. So
Click on the images.
click on the image, I just pen. Okay. I have used a laser pointer, but I have to stop that laser pointer. I think I just. Yeah, sorry. So that's the trachea. You can see the trachea there, and on one side is nicely seen esophagus. So most of us think that esophagus is exactly posterior to trachea, but here it is posterolateral, and there are papers, if you look at the anatomy, where the esophageal position, you can see the esophagus. Nobody can miss the esophagus round, and you can ask the deglute. So there is this, even the tracheoesophageal groove, there is a recurrent laryngeal nerve. So we always talk about regional anesthesia and interscalene block and laryngeal involvement if too much of if drug sits here. So that's the importance of this area for an anesthetist. So when we see this esophagus very well, there is another question where we should be providing the cricoid pressure. So I think this has changed the way we look, and once we park the probe, we see the esophagus, and then we may just push the esophagus and try to occlude it at the time of, rapid sequence induction. So this is another insight. And if you know where is the anatomy, and without, just doing it blindly, it's a good idea to utilize this opportunity. Another important thing is whether the tube has gone endobronchially. So we can inflate the cuff with saline, which is seen as a hypoechoic structure. And if the cuff has gone beyond the third tracheal ring, you can very well say that it has become endobronchial or something. And this is useful in pediatric population when we are really scared. We do not want, so we always keep that pediatric stethoscope and everything. So it's a real time thing to just place a probe and see. The airway examination is not complete unless you see and put it over the second and third intercostal space to see pleural sliding. And it has now become a stethoscope for all the physicians who are dealing with airway, anesthetist and the emergency physician. And the visceral and the parietal pleura, they ride over each other and it produces a shimmering effect, and which is seen very well. But if it is not visible, then you may put an M mode. M mode is the motion mode which picks up motion at the line of interrogation. And because of the motion, the distal area is seen granular. It is like a seashore, and deep inside is a calm sea where there is no movement. Now, this is useful when we are doing with DLT, though the gold standard for DLT is definitely pediatric fiber optic intubation, the use of pediatric fiber optic scope for seeing the blue curve and everything. But this technique, there was this paper from Tata Memorial Hospital, Mumbai, and Dr. Jiggy Diwati and group, where they have proved that it is better than auscultation. So ultrasound is superior to auscultatory methods, and you can see whether it has become endobronchial or not just by placing the probe. And in pediatric population, there is another advantage where you can, because the sternum is not calcified, so you can even see the movement of diaphragm very well. So just nowadays, most of the machines with click button, you can change the probe and see whether it is moving or not, and you can confirm. So this is about intubation. So I have spoken about intubation, how to choose the size of the tube by looking at the tracheal diameter in the subglottic area. I have said how to detect endobronchial intubation and in long axis view. And we have also seen the importance of esophagus, whether the tube has, and where to park the probe. So the parking of the probe where it should be. And this is in pediatric patients and anywhere where you can see esophagus and trachea together. So this is so somebody was asking me, you need to have a machine. So I said yes. If you have a machine and you are another assistant in the OT, it's good idea that you get arrange all the ergonomics and place the probe there. We come upon this smaller part before going over to other aspects of difficult intubation, because extubation is ultrasound helping me. So Dr. Apeksh sir was talking today morning about the vocal cord movement and spraying it on and post thyroid surgery. So vocal cords we see very well. The true vocal cords are seen as black line, and the false vocal cord are gray, and then there is a arytenoid cartilage. So simultaneous movement of arytenoid cartilage rules out vocal cord palsy. So these are some of the videos. I'll try to show these videos where the vocal cords are moving. I have YouTube channel with all these videos, and some of them are even scanning videos, even better. You can visit that and see. So this is the another video. Here you can see the vocal cord movement, the the the, the hypoechoic black area. I'm asking the patient to say E, and you can see the vigorous vocal cord movement in the middle. And another, the final video, just to show you how the movement can be. Saying E, and you can see the vocal cord movements also. He's saying so this was just to re-emphasize. You can see the black as true vocal cord and the gray as false vocal cord, and lower down are the arytenoids which are moving simultaneously, ruling out the vocal cord palsy. So in thyroid surgery, it is good idea to use Bailey's maneuver. Some of you may be knowing Bailey's maneuver, where ET tube is removed and we just place LMA, and then after placing the LMA, we can see the movement of vocal cords very well. Most of the time after thyroid surgery, when surgeons are asking, most of us do laryngoscopy, and I find it very barbaric. 90% of the time, nobody sees anything, and everybody says, "Yeah, sab theek hai, everything is fine," and we just move on. And this is a ritual more than a scientific thing. So I think we can be more scientific and objective, and we can store these images, and we can show it to relatives and surgeon also. After Bailey's maneuver, you can pick this up very well. So post-extubation stridor is another important area. Some of us do have ICU or HDU, or post-surgical, we extubate second day. So there are different ways by which we can look at the trachea, and one of them is this paper recently from 2023, where it has looked at the laryngeal air column width difference in predicting the risk of post-extubation stridor. Now, this is a very upcoming area. You need little, fine tuning with measurements and little advanced machines. 2, 3 ways I'll give you some idea about how people look at it. One is people look at the tracheal diameter, and if you have, say, tracheomalacia or scabbard trachea, it is like conducting a leak test with ultrasound. So if there is a lot of tracheomalacia, when the cuff is inflated and the cuff is deflated, there is lot much difference in the tracheal diameter, because tracheal diameter is flabby. The trachea is flabby in tracheomalacia, so that we can expect post-extubation stridor. Whereas when the trachea is quite sturdy and there is not much of change with inflation and deflation of ET tube, then you can say that the leak test is that is how we are conducting it. Another way is looking at the air column, and when the cuff is inflated, it appears more of rectangular in shape. When it is deflated, it is trapezoid in shape, and we measure the width. And any width more than 16 millimeter, it means a lot of inflation deflation changes are happening. It could be we can expect post-extubation stridor. Of course, this is a really fine area, more practiced by intensivists, intensivist when they have to take decision about this area. We can utilize it for our patients who require ventilation for more than 24 hours, especially the oncosurgical patients. Cricothyroidotomy or front of neck access is very, very crucial. And again, we have to remember the anatomy, the thyroid cartilage, which creates a hypoechoic sort of a ultrasound picture. Then we have a cricothyroid membrane, and then the purple one is the cricoid cartilage. So what should be the position? It can be done in a transverse scan, which is a TACA method, or in a parasagittal scan using sting of pearls method. So I'll be showing you one which is easy to correlate. So one is the thyroid cartilage, which is creating a black hypoechoic area. Two is the cricoid cartilage. So, and three is the tracheal ring. Here you have string of pearls appearance. So whenever you have string of pearls, the tracheal rings, and suddenly you see this step from 2 to 3, downward slope, that's a hallmark for cricoid cartilage. So that is how we should be identifying the cricoid cartilage. We must know where is the orientation marker of our linear probe. Here the one on this side is the cranial word, and below is the caudad. So when we identify the structure as the cricoid cartilage, then we have to see this white line. This is air mucosal interface. Whenever we have a air mucosal interface, it creates a white line. So any structure above a white small thin lining is the cricothyroid membrane. So if we see this white line between 1 and 2, you have to bring the structure in the middle of the screen, use M mode as a marker. Just if you press the M mode button once, it will divide the whole screen into 2. So we just have to bring the structure in the middle of the screen and try to mark it with the marker pen, or we can just place and move the probe, caudad and cephalad, and try to place the needle. Needle is seen again, it creates a metallic artifact, and we can see the middle of the screen, and we can easily mark this area as the cricothyroid membrane. So this is how we do marking. Now, what we have learned from experience is when we are called for cricothyroid membrane, how we are utilizing it. So patients with difficult intubation, say in ICU, when we had this issue about patients with stridor in sitting position, we have done intubation in sitting position. So we have prophylactically placed a 16 gauge cannula there. We have punctured the cricothyroid membrane with the ultrasound, and then we have attached a 2 cc syringe, and then as we know, the 6.5 the universal connector and umbuing. And as we have punctured and placed a 16 gauge cannula there and removed the stylet, we have even done some amount of spraying with 2% lignocaine and some topicalization. So as we are able to attach umbu to that and do some oxygenation, it has provided us a little additional 10-20 seconds to complete our awake fiber optic intubation drill in sitting position. So this is one school of thought, and this has been promoted, advocated, and popularized by Dr. Pankaj Kundra and team, where the question is, for a critically ill patients or a high-risk patients, we do put radial artery cannula, and at the end of surgery, we just remove that cannula and the patients are safe. So in a difficult airway, why not to not only mark, but go one step ahead and just puncture it and place the cannula, because in emergency, whenever there is trauma, it is very, very difficult to get any cannula. And then it can be a marker if in emergency, if somebody needs surgical tracheostomy, it can help the ENT surgeon also, because sometimes the neck is too difficult, a big thyroid, a fixed mass, a static neck, patient in stridor, in sitting position, we just hardly get a one best chance to perform. So this is one school of thought. I would like to know in the end, if Apeksh sir, he wants to contribute in this area, but this is, we have practiced and it has helped us, because it is very difficult to conduct these intubation drill in sitting position, and some oxygenation we also have to maintain that 16 gauge cannula in straighter position. Sometimes the patient tends to cough, and a lot of secretions do come through the cannula, so it is difficult to oxygenate. But in that case, a little bit of spraying has helped, and we could still maintain some amount of oxygenation before going ahead with the drill. So we can utilize this marking of the cricothyroid membrane, or prophylactically puncturing it before proceeding with a drill. Most of us do topicalize the airway, just we do a one puncture. Why not do a puncture with a 18 or a 16 gauge cannula? So this is one thought to ponder, and you can decide if it can be applicable in your case. Now, coming to the last area, which is difficult airway, and I am coming to this area last because many of the people who are using ultrasound, they say that this area is still emerging, and there are no clear-cut guidelines to say do this and do not do this or something like that. So I'm just letting you know a few concepts here, and what is the literature review and how we can apply it. We have done research in our department with this. We have used few parameters, and it has helped us, and it is providing us an opportunity to look at the airway. Now, this was whenever there is difficult airway, I know the airway experts, Dr. Apeksh sir is there. In general, how we look at airway is, one, it could be challenge in mask ventilation. So is ultrasound going to help me with mask ventilation? So we have latest article which was published last month. It says that difficult mask ventilation, hardly 2 or 3 papers are there, and we need more studies. But still, looking at the hyoid bone, we can predict difficult mask ventilation. So skin to hyoid bone distance, little bit, it can give us some glimpse. Then difficult laryngoscopy, yes, tongue thickness, tongue volume, and there are parameters to help us with predicting difficult laryngoscopy. Third is difficult intubation. So all those anterior soft tissue structures and skin to vocal cord, skin to epiglottis, skin to isthmus, skin to hyoid bone, they all are telling us. Then the pre-epiglottic space. Now people have even looked at the glottic to epiglottic angle and other things. So it is giving us a lot of information. So conventional method, so none of the article has said that we have to stop conventional method. So it is not a replacement for our conventional assessment method. But yes, it is a very good adjunct. If you combine ultrasound information with your conventional skills, it is going to be, it has shown to increase sensitivity and specificity for success rate of difficult intubation. So there are several articles on conventional and compared, and they found that ultrasound is beneficial. They have looked at the anterior soft tissue and tongue thickness to predict difficult intubation. Now, this was the article which was published just a week, 2 weeks back, and this is a systematic review for preoperative ultrasound for predicting difficult airway, and it has predominantly looked at all the previous studies, and in neutral position and in extended neck position. So skin to epiglottis, mid epiglottis distance was one, and then skin to anterior commissure, the tongue thickness, and the hyomental distance ratio, inflection and extension, and even it has talked about EG angle. So at least 3 parameters which are, if we use, one is skin to mid epiglottis. Second could be the tongue thickness. Third could be the hyomental distance ratio. At least 3 or 4. It will give you some fair idea. And I think what ultrasound has done is we have started anticipating airway in a better fashion, and therefore calling for help, getting all gadgets in place, making a backup plan, and it has reduced the anxiety with us, because most of the time it is a lot of adrenaline when it is difficult airway. So till this stage, I think ultrasound has caused some dent in reducing the anxiety, and anticipation skill set is considered. So we have looked at various studies, and what are we talking when it comes to difficult mask ventilation? So distance from skin to hyoid, if it is more than 1.4, it predicts I'll be showing you the literature review as well. So it is prediction of difficult mask ventilation, but the latest article tells that more and further detailing and studies are required in this regard. Difficult laryngoscopy, the tongue volume, the tongue thickness. Most of us practice tongue thickness. Tongue volume is another skill set where the articles have to a consensus something around 5.8 to 6. When the thickness is more than that, then it is difficult laryngoscopy because tongue is coming in the way and it is difficult to squeeze it and move aside. And when it comes to intubation, then we have all the parameters to look at the anterior soft tissue. How much is the thickness? So skin to hyoid bone, skin to epiglottis in neutral as well as in hyperextended neck. So once the neck is extended, probably it reduces some amount of soft tissue there. Then skin to anterior commissure to vocal cord, then thyroid isthmus. Then they have looked at hyomental distance ratio in neutral and extended position. Sometimes patients are in lying down position and it is difficult to make them sit. So this type of a parameter can help you to assess neck mobility, whether it is neck is mobile or not, looking at this ratio. Then there is this the periepiglottic space. People have looked at the space very too much. I mean, they have involved a radiologist to look at it, and even there are papers from radiology side as well to help them assess this soft tissue area. So I'll be talking on that. And then recently the glottic to epiglottic to glottic ratio. So yes, I'll be demonstrating some of the tips. I have used these parameters. So which parameters I have used, I can tell you what are the challenges. So skin to hyoid bone. Now there are papers in obstetric anesthesia, and what simple parameter they have said is whether we can see hyoid bone or not. So if hyoid bone is seen, it is probably easy intubation, and if hyoid bone is not seen, it is probably difficult intubation. And even this simple criteria has worked well with good specificity and sensitivity. So in obese patients, it is sometimes very difficult to visualize hyoid bone, or in patients with pre-eclampsia, eclampsia, and all those. So presence of hyoid bone is one of the important criteria. Any value more than 1.4 is difficult mask ventilation also. This hyomental distance ratio, we do it with neutral position and extended neck position. So how the image will, so any hyomental distance ratio less than, so extension divided by neutral position. So ratio should not be near 1. It should be more than 1. So it means it has some flexibility. So what are the images? So this is in neutral position and then extended neck position. So we see the hyomental ratio. So in extended neck, it is around like 4.3 or something, and it is 3.3 in neutral position, and we calculate the ratio. So definitely 4.3 divided by 3.3 ratio is more than 1. It means neck is quite flexible. When the ratio is almost 1 or less less than 1.1, it means neck is hardly mobile, and we have difficulty probably achieving good laryngoscopic vision. So skin to epiglottis, people are talking about mid epiglottis, where to assess, at the apex, at the mid, and or at the base. And different articles do not say anything about it as where they have assessed, and most of the studies, they just have come up with a cutoff point of around 1.9 to 2. And this is the black hypoechoic area. So instead of cursor up till here, probably the air mucosal interface is white line, and people say that we should be calculating from the base, like to write down there. And now the most of the articles are coming up, they say mid esophageal. So even some of them, instead of using a transverse scan, people are using a parasagittal scan. So more and more information. So till date, most of the studies have used this black hypoechoic thing as epiglottis, and they have measured skin to epiglottis distance from its top to the skin. And whenever the value is more than 1.9, we have used it in our study as well, and it fairly correlates with our patients. Actually, one of the important fact is we do not have a normalcy data with Indian subpopulation, probably I may be, as far as I know, Apeksh sir may be telling us more about, but we are mainly dependent on, as the ultrasound in this area is emerging, we have to depend on whatever ethnic, whatever, the Western population data, sometimes we have to depend on. As we can see, the size of ET tube in our indication versus those who are from America or UK, and how there's so these so do not be very rigid about a number, because different studies will have different. So you need to think of a range for all these studies, and you have to look which parameters they have looked at. So this area above the epiglottis is the I was talking about the pre-epiglottic space. So people have looked at this pre-epiglottic space, and when the whole of the area is more than 5 centimeters square, when this whole area is more than 5 centimeters square, or a value of, when the thickness is just measured, it is more than 2.5, it is Cormack-Leand 2B. So this is, even people have drawn a midline and divided into two, 10 on this side, 10 on this side. It is also reducing. So only 2-3 slides, some more slides, almost it is done. I think so. This area again is, people have looked at it. Sometimes the ratio, when we are talking about the vocal cord to pre-epiglottic space ratio, you may need to place the probe in the cricothyroid area and just slant it upward and measure the distance and carry out the ratio. It's a challenging task, but at least 2-3 parameters like skin to epiglottis. What I have showed is the hyomental distance ratio, and we'll see the tongue thickness as well. So tongue thickness is usually using a curvilinear probe. You can do it in long axis or short axis, and this is how the tongue will appear. And in the neutral position, you can do it at the base of the tongue. In the tongue should be, the neutral position of the tongue is, it should be just above the upper incisors. In the normal, it should not be withdrawn. So we do this and look at, so it gives us a fair idea what should be the challenge with laryngoscopy. Or suppose you have done a surgery where there could be tongue edema. So post-op, especially with cleft lip palate or something, this is just a thought where all those indications where tongue size may be more, you can predict it whether the laryngoscopy is good enough to displace the tongue. Now you can see another parameter which has recently been discussed, and this is the TP space, the palatoglossal space. So in this view, we see the palate, and between the tongue and palate, there is a space. So there is no such parameter as of now. When we are assessing the airway with a conventional method, we ask for MPC score. We ask the person to put out the tongue. So when they put out the tongue, we see the posterior pharyngeal wall, the MPC grading, but it cannot be extrapolated to when we are doing mask ventilation. So this is the position of tongue in neutral position. I mean, the tongue is inside the mouth, and the mouth is closed, and there is a space between the palate and the tongue. So it is telling me that probably I'll be able to ventilate this patient with bag and mask very well, because there is a space. If there is no such space, then probably we need airway gadgets, probably oropharyngeal or a nasopharyngeal airway, because tongue is going to fall. So in a this is a very useful parameter of palatoglossal space, and it has almost 91% sensitivity. Even if you answer the question as yes or no, if it is yes, then 91% sensitivity is there that you'll be able to mask ventilate this patient. So what are the sensitivity specificity measurements? This was another article in 2020, and I was just re-emphasizing this point that all these ultrasound parameters should be used in combination with malampatti, with with all the regular parameters, where and when we have combined this, then the specificity and sensitivity increases to around 90%. So you can see here 93 and 86 when they have combined skin to anterior commissure distance with periepiglotic space to epiglottis and vocal cord ratio and hyomental distance ratio, the Malampatti and TMD, so thyromental distance. So combination strategy works very well. Percutaneous dilatational tracheostomy, I would not like to overemphasize, but this has happened when one patient of operated neck dissection was taken for tracheostomy, and we just placed the probe and we could show lot many vessels there. So instead of a horizontal slit, the surgeon has modified his decision to make a vertical slit, and this is for surgical tracheostomy. And even with percutaneous dilatational tracheostomy, you can see which tracheal ring and whether there are any vessels there by putting a color Doppler, whether the thymus, sometimes the thyroid artery, which is a direct branch from aorta, can be there, and we should avoid because it can bleed to death. So all these vessels before planning with any incision or any dissection in that area should be done very well. So you can see, put a color Doppler and identify these vessels. So vocal cord pathology is another aspect, and sometimes the musicians, we have operated stars, singers, and it is good idea to just do a prophylactic scan. Sometimes you may see a cyst or a polyp or a nodule, and you can predict, because we have to take that consent and we have to predict whether voice quality will change or not. So a quick scan, preoperative scan, is a good idea to predict all these. It is good to use a supraglottic device, but some surgeries do require intubation, and we can tell them with a lot of confidence that apparently as of now vocal cords are fine, because this in one patient we have seen one polyp and it was incidental finding, but it could happen that at the time of passing of tube the cyst may break. So LMA positioning is another important aspect, and if you have a probe just in the same position where you have placed it for ET tube, you can see whether it is getting dislodged. You need to have a focus question, and you try to find answers. So we are not having any specific answer. If you have some specific question, correlate with the anatomy, try to see ultrasound anatomy and try to adjust. So some people have looked at the anatomy and they have changed the position of LMA so that it suits well. So this can be an additional step. Maxillary sinusitis is another aspect where we were worried about COVID times when there was a lot of mucus. So if there is a air fluid level in the maxillary sinus, it was a relative contraindication for nasal intubation because all those fungus may go posteriorwards. So we used to look at that time. Fine, this almost completes the airway assessment. I would just like to highlight one important point, that airway examination is not complete unless we look at the gastric ultrasound. Though this is not my topic to cover today, but aspiration risk, unless we rule out, it is like a lower airway assessment. So we have to see the gastric pyloric antrum. And I think if you are interested, you do a focus workshop with us. We'll teach you how to identify liquid and solid content. And any volume more than 1.5 ml per kg for liquid is risk of aspiration. Any presence of any solid content is also risk of aspiration. We have done this, and when we have started doing this, our obstetrician and our surgeons accepted it, because we could show them that it is a high risk, and they would say otherwise say 4 ghanta ho gaya, 4 hours I've done, and why not? So now they can clearly see the content, and we could convince them that it is a solid content, let us wait, and they have accepted it. So there are good charts available. It can tell you the cross-sectional area, the volume, and it's a very, very easy step. Our PGs are doing this. Chart is being we have attached it to all our ultrasound machine for ready reference. And so in summary, what has ultrasound changed is difficult airway. Yes, it is still emerging. We are looking at the anterior soft tissue neck structures, the head, the epiglottis, the tongue. Critical situations, definitely the cricothyroidotomy, the percutaneous dilatational tracheostomy, even the vocal cord movement after surgery, the post-extubation stridor, these are real time and they are helping in a very, very big way. Gastric content aspiration is integral part of airway management. Real-time placement of ET tube, DLT, LMA is better confirmed with ultrasound, and especially you are in teaching institute, and there is a large supportive evidence in favor of ultrasound. So thank you very much for patient listening.
Thank you, sir, for excellent presentation and easy way of explaining the ultrasound of airway. Over to you, Jeyaprakash, sir.
Thank you, sir. Thanks a lot, sir. Very excellent presentation it is. We have some queries, sir. Is this predictions of difficult airway is validated in pediatric age group also with ultrasound?
Yeah, so there are papers with pediatric, but pediatric assessments are most of the time they talk about anthropometric measurement for a given subset of patient. I mean, what are the calculations for a 5-year-old child dating for a 9-year-old child? So these are the papers when they talk about, because there are papers with the diaphragmatic predominantly with as they talk about extubation. So pediatric cardiac anesthesia many papers are there when they talk about the post-extubation stridor and predominantly the diaphragm and other areas. So pediatric airway again is a evolving challenge. So what I am trying to suggest here is validated studies are coming up, but we do not have that much of data, though I showed you the 2023 latest article, which has done a meta-analysis, and at least they have come up with at least 2-3 parameters in adult subset of population. So it's emerging, but as you can understand with pediatric, there are challenges. But I would urge, my practice is mixed practice. I am not exclusively a pediatric anesthetist, but what has helped me in pediatric population is airway is seen even better with pediatric population. So if you have a child of 8 or 9 years, it is good idea to assess and see all the structures. Structures are very well seen. So it will take some more time to analyze questions. People have started utilizing it to see the gauge of the ET tube to confirm whether endobronchial intubation or not. So all those basic principles, whether ET tube has gone in esophagus or whether it has gone in the trachea. So these simple basic principles of airway are definitely being followed in pediatrics, but specific pediatric related studies are still emerging to reach to a level where they have standard guidelines or validated outcomes. Some papers I have read, but I am sure Apeksh sir and still there are many other delegates also. They may be knowing few more things, but to my knowledge, it is still emerging. Hopefully, I have answered.
Sir, is there any way of identifying that submandibular space assessment with ultrasound? Exclusively submandibular space?
Yeah. Actually, the palatoglossal space, which I have showed for the tongue thickness, there you can actually place it in the submandibular area only, and you can see the palatoglossal space very well in a better way by placing in the submandibular area. And you see if there is any space when the tongue is in neutral position, is there any space between palate and tongue, and whether we can talk about ventilation, mask ventilation. So this is useful. Sometimes some patients are obese and we just place the probe in the submental area, and we tend to see, and there is a good palatoglossal space. So we should not be over worried that just because patient is obese, we will not be able to do proper mask ventilation and we will struggle with ventilation. So in that case, I would probably choose non-depolarizing muscle relaxant. When I don't see any space, probably my choice would be a rapid sequence induction, and I keep one person ready, probably with more advancement of gadgets, and probably I'm anticipating a difficult ventilation. So good pre-oxygenation, probably all those. Now this is another topic. Now we have even facilities with apneic ventilation. We can achieve very good pre-oxygenation, so we have some advantage. So all these gears will change if we are anticipating something. So sometimes we don't know which patient I'll have difficult mask ventilation. So at least some areas we have this benefit. And what Apeksh sir has told about squeezing, the capacity to squeeze this area with the laryngoscopy and all that, that we really don't know whether we'll be able to displace or squeeze and how much it can be moved, because that cannot be done with ultrasound unless somebody is doing a real-time laryngoscopy and then we are measuring these distances. So that's a different topic altogether. But tongue volume and other things people have calculated. But again, it requires many calculations, and unless you have some background of special training in this area, all those fine tuning, or you have a radiologist friend, then you can still progress in this. A little bit of practice will give you fair idea about the airway, but many areas are still being explored, and you will be astonished to see how people are working so aggressively in this area.
So is there any specific grading system for prediction of difficult airway when you use ultrasound with ultrasound?
The paper which I showed has come up with every test has got its own values and cutoffs depending on what material methods they have utilized. So if like skin to epiglottis, mid epiglottis, most of the papers showed 2 centimeter as cutoff, or tongue thickness as 5.8 to 6 as cutoff, and the hyomental distance ratio. So you have to choose 2, 3, at least 3 is one of the recommendation. You combine these and then try to see with individual cutoff, and then you can predict this. So difficult airway. Some of the aggressive people using airway ultrasound, they are convinced that we are still in the developing area in as far as difficult airway prediction. So first we have to start more with normal airway, and most of the papers which are talking about all these have not included difficult airway in their study design. So if you critically analyze this paper, the sample size is not having. Some studies do have included obese patients and difficult airway, but most of them are like straightforward airways, and then we are trying to extrapolate in difficult airway. So still we'll have to wait for that. But yes, as we have started parking the probe at the time of intubation, as we have doing prophylactic cricothyroid puncture, as we have any airway pathology we would like to scan. Even 2 days back, somebody asked me, they were doing parathyroid surgery, and we have just scanned the thyroid gland, and we could show a lot of vessels, we could show cysts, and this could help the surgeon in real-time planning of incision, though there was an ultrasound report. Putting a probe will help you to developing for asking the right question. So unless you do more scans and lot of try to see what is the question, and if we can answer this. Somebody was asking me, what about presence of a fistula or presence of parapharyngeal abscess or something. So we have placed the probe, we have seen the abscess, you can see a hypoechoic cavity, you can help and draw, put a caliper and measure the distance and help the surgeon. So unless you have a very specific question, where should be my incision on this whole surface, which is all swollen up? Where is the thyroid gland? Sometimes, in a thyroid patient, we cannot identify trachea by manual method. So just placing an ultrasound probe will help us, like it is extreme left, the trachea has gone. And at least we have some idea where how to push, how to maneuver. So you have to develop a skill set of asking right question and try to analyze if ultrasound is helping. So most of the articles are after 2014-15. So it is still 7, 8 years, 10 years, and we are growing ahead with all this evidence. Hopefully, I have answered that.
Yes, sir. Yes, sir. Even recently we have seen that lot of thyroid cases we can do that a level of deviation of the trachea before we place the.
Yes.
Uh,
Well, the surgeons are scared. Sometimes people think that our protection is ENT surgeon. But when I have called ENT surgeon for all these difficult cases, they were equally scared as anybody else. They said, okay, you called us, but you tell us what to do, because nothing can be done most of the time. The structures are so thick, difficult to palpate. How can I get you will have to do fiber optics somehow. So we showed them the trachea, we placed some, small puncture there. There is a guidance. Then they can work on that area and try to fix it. But it's a challenge, and airway is always an emergency. And as a perioperative physician, as a anesthetist, we are looked upon as the leader in this area. So everyone else depend on us to help us place the tube. So all these airway gadgets, kit for advanced airway and everything should be ready. And therefore, in COVID times, we have invested a lot of money with our department has video laryngoscope, high frequency nasal oxygenation cannula. We do have pediatric fiber optic scope for confirmation of DLT. And I think it's worth investing in airway gadgets because it's a very, very crucial step and one chance. So all those airway gadgets, even we have the LMA protector and other things also, and we have it is beneficial. I mean, it's even when you have the LMA placed, you can. So it's a like, if you are passionate about it with the ultrasound and focus, you have some different question, you try to analyze, we just see and we find answers. And I was just explaining, re-emphasizing how the bougie was placed, and 3 times it has gone in esophagus. Now think of a situation if we would have really railroad and passed the tube and then checked, it would have created a lot of mess and anxiety and stress and increased risk of all the catastrophe. So it is helping us. I mean, if any interrogation, any intervention is helping to change my decision, I think it is a very good intervention. So, and ultrasound has helped us that we could say, no, this tube has not gone in, or, it's not trachea, it's not cricothyroid membrane, it's not the endobronchial intubation has happened, your tube has gone excessively in. This probably is not the right size tube. Here, the tracheal diameter after post tracheostomy patients, all those, no, where CT scan, sometimes they show some small chinks, sometimes. So dynamic airway assessment can be done with the help of ultrasound, because the airway size may change with breathing. That cannot be picked up in each and every CT film, because it depends on when the shot was taken. So sometimes it may show very small change, sometimes. So there are advantages, disadvantages, and of course, ultrasound is again an observer dependent technique. So more and more you are refined in that area, you will be able to predict in a better way. Yes.
So one last question, sir. Role of ultrasound in airway blocks as a regional anesthesiologist.
Yeah, so that that I have not covered. But if you could see the Adam's apple, and then the hyoid bone. So in between is the thyrohyoid membrane, and this thyrohyoid membrane, if you block anywhere, it will involve the superior laryngeal nerve. So this is the superior laryngeal nerve block. Most of the time, people palpate the hyoid bone and the cornu, and then they just beneath the hyoid bone. So basically, they are infiltrating with the local anesthetic in the thyrohyoid membrane, and it is causing a good block there. Another is a transtracheal installation, which can be aided with ultrasound and help to get the right puncture. The glossopharyngeal nerve block, and again requires little bit of training, and most of us don't do it actually. So these two blocks, the superior laryngeal and the transtracheal installation with ultrasound, because many times we poke the needle and there is no airflow. So why not just place a probe and just do it in a one go, because the patients are much more comfortable with that. So that can be beneficial. Another area is people have done mandibular nerve block and maxillary nerve block and other areas for commando surgeries and other. That is another complete area of discussion.
Thank you, sir. Thank you. Thank you for excellent presentation and discussion. Edward, sir, any other questions you have, sir, or shall we
No, sir.
conclude?
I would like to know comment of Apeksh sir in few areas about ultrasound. What is his take? And
Sir, okay, sir, are you there, sir?
not there. Okay.
Okay. Sir, thank you very much for
Thank
today.
you, sir.
Excellent presentation by the two speakers, Dr. Amit and Dr. Apeksh. They have thrown more light on the understanding of the airway. Thank you very much, sir, Apeksh sir and Amit sir. And also I thank the coordinator, Dr. Rajesh, Jeyaprakash sir also. I thank the sponsor, Akrula, and the media partner, that is Anaesthesia TV, and also I thankful to the host A1 Logics. Thank you one and all. We will meet the next month with another interesting topic. Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, Dr. Edward and Dr.